بسم الله الرحمن الرحيم. I'd like to present this upper tibial osteotomy to the review course of Benha University with thanks. This basic lecture would like to demonstrate that the new trend for treatment of osteoarthritis is preservation or tendency to preserve the joint, that we reach the non-arthroplasty treatment of osteoarthritis. Treatment of osteoarthritis in general is non-surgical and surgical. The non-surgical is non-pharmacological and pharmacological, which is symptomatic and disease modifying. And the surgical treatment is based on arthroscopy, osteotomy, and replacement. The future is to try to keep away from replacement, and the osteotomy is the keystone in this lecture. Why deformity is important? Because deformity goes hand in hand with wear. Because this stress over the cartilage or equals force over surface area. If you put 100 kilogram over an 10 by 10 centimeter area, that's 100 square centimeter, then each centimeter takes 1 kilogram. If you put the 100 kilogram on 1 centimeter, then it is 100 times more. That's 100 kilograms over this centimeter. This picture shows that in the midline is the neutral position of the knee, and as the pressure on the medial compartment in the red line goes rising up and increase from 2 to 12 megapascal as the mechanical axis shifts from 0 to just 15 degrees of varus. And the opposite in below occurs with the lateral compartment with a genovalgum deformity. In the normal mechanics, the medial compartment takes 55% to 70% of force on the medial tibial plateau in the stance phase, because there is an adductor moment during gait. With just 6 degrees of varus, this increased to 90 degrees load on the medial compartment versus 10 on the lateral compartments. The prevalence of deformity is high. The incidence of varus deformity in particular may reach up to 80% of the population of knee deformity. The important anatomy of the mechanical axis of the lower limb is that the weight comes from the hip joint, passes to the center of the ankle joint, and in its way passes almost in the center of the knee, slightly to the medial side. The top of the tibial plateau makes an angle with the anatomical axis of the tibia, which is at the same time is the mechanical axis of 87 degrees. Why 87 degrees, not 90? Because when we walk, we don't walk with the ankles below the hips, but we walk with the feet in the midline, one in front of the other, and this makes adduction of 3 degrees of the lower limb for the mechanical axis, and that's why with this adduction 3 degrees, the horizontal of the top of the tibial plateau is in horizontal line parallel to the ground. And does the osteotomy help with this? Yes, it does. It redistributes the load over the compartment. It stops the disease progression by redistributing the load. And there is evidence that it leads to regeneration of the cartilage. It preserves the joint mechanics and improves symptoms with solid relief of pain, probably because of decompressing the hyperdynamic state and probably because of relieving the pressure which causes microfracture of the porotic bone. And the importance of the load over the menisci is another thing. With overload leads to disruption of the menisci with occurrence of special injuries like the root avulsion or root tear. The cartilage itself is priceless. We know from the lubrication mechanisms that the nutrition of cartilage and health of the cartilage depends on slight pressure and movement, which lubricate and nourishes the cartilage. Overpressure or overload over the cartilage interrupt this dynamic lubrication and leads to degeneration of the cartilage. But what about the natural history of upper tibial osteotomy? The opponents of upper tibial osteotomy say it deteriorates over time. 80% only satisfactory results at 5 years and decrease to 60% at 10 years. Some reports average 7 years before conversion to a total knee. The rate in North America of upper tibial osteotomy has declined because of this, where the rate of total and uni knees has steadily increased. However, the results of total knee arthroplasty shows only 20% unsatisfaction according to the European arthroplasty registry. There may be unfairness on the upper tibial osteotomy because we have insufficient knowledge about the selection, planning, and performing the arthroplasty, the osteotomy. These courses, like the Great Hampshire course in UK about osteotomies around the knee, the new innovations and techniques. There is even congresses about osteotomy congress. The title Preserve the Knee Joint. So if the upper tibial osteotomy is well selected, planned, and performed, it should give better results, and probably in the future, it may preserve the knee. For selection of the patient, the favorable results include young active patients under 60 years, and now we talk about 50 years, purely unicompartmental disease with ligament stable knee, preoperative range of motion of at least 90, we say now 100 degrees, body weight not exceeding 30% over the normal body weight, and non-smoker. Contraindications. The absolute contraindication is rheumatoid arthritis or inflammatory arthritis, where it could not be a unicompartmental affection. If the knee flexion of less than 90 degrees or even 100 degrees, this is the failure increase. Flexion contracture of more than 15 degrees, now we talk about 10 degrees. More than 20 degrees of correction needed. And actually, I disagree with this because the new techniques may lead to more than that with good results. The lateral tibial subluxation of more than 1 centimeter. Ligamentous instability is probably not a contraindication. It's even now an indication of upper tibial osteotomy to restabilize the knee using the upper tibial osteotomy, and maybe an adjuvant to ligament reconstruction surgery and osteoporosis. Before we choose the type of upper tibial osteotomy, we have to think of the XYZ axes and planes. And in each of these 3, we can get angulation, rotation, or translation. So in the coronal plane, we get varus and valgus. In the sagittal plane, we can get flexion recurvatum or recurvatum, pro-recurvatum, or increase or decrease of the slope of the upper tibial plateau. We can get rotational deformity like this adolescent. It's common in adolescents with the residual deformity after rickets or tibia vara. You can get much rotation associated with varus deformity. In the patellofemoral, we may need to make an anterior translation of the tibial tuberosity, but because the most common deformity in the Egyptian population is varus, it constitutes 80% of the deformities around the knee. So we will talk about valgus osteotomy or valgus producing osteotomy of the upper tibia. Actually, in some osteotomies, you can combine correction of more than one deformity, like you correct the varus with the internal rotation, and you can change the tibial slope by maintaining it or increasing or decreasing it. And at the same time, you do anterior translation for the tibial tuberosity by advancement. There is 5 basic types of upper tibial osteotomy. That's the lateral closing wedge, that we take a wedge out and then close the gap, or medial opening wedge, that we make a cut and then open the gap, or lateral closing medial opening combined, or the dome osteotomy, and lastly, the distraction calotasis by external fixators. The barrel vault osteotomy of Mackay depends on arc osteotomy around center. It actually shifts. It allows anterior translation of the tibia, but technically it's difficult and its complications can be serious. And I think it fall out of favor now. Before planning and commencing the osteotomy, we need to know exactly what is the deformity or deformities, where exactly is the deformity, how much is the deformity in degrees, and if there is secondary deformity which must be corrected. 90% of the data we need to know about osteotomies can be collected by examination. During sitting, you can get idea about the range of motion of the knee and the muscle power getting up from the sitting position. In the standing position, you have a good idea about deformities by looking at the patella and position of the feet. During walking, you look for lateral thrusts, which is increase of the varus deformity during stance weight bearing. Lying flat, you recheck the rotation and check whether this deformity is correctable or not. Check for ligament instability, and you feel for patellofemoral joint osteoarthritis. To do the workup before doing the osteotomy, we need to do radiographs in the standing position, must be in the standing position, long films with the rotation corrected by making the patellae facing forwards. We do lateral views for the patellar height. We do the skyline for patellar osteoarthritis, and we do scanogram, which measures the length, the angle, the distance of the mechanical X. You must do CT for question of rotation malalignment. You must do MRI for the knee if there is any suspicion of internal derangement or question about the degree of osteoarthritis. What about arthroscopy? Arthroscopy is commonly done before doing the osteotomy for internal derangement, classification, debridement, and adjuvant treatment if it is to be done with the upper tibial osteotomy. The important points in anatomy and should be looked at in the long films that this angle of the medial proximal tibial angle, we call it MEPTA, is 87 degrees. And we talked about why it is 87, not 90. And it is the angle between the top of the tibial plateaus and the anatomical axis, which, by the way, is the same as the mechanical axis of the tibia. Second thing is the angle between the anatomical axis of the femur and the mechanical axis of the femur, which is 6 degrees. And lastly is the joint line conversion angle, which is the angle between two lines, one touching the distal parts of the femoral condyles and one passing by the top of the tibial condyles. And this angle could be 0 and up to 2 degrees. The other thing is the mechanical axis, which a line passes from the center of the hip joint to the center of the ankle joint, and it usually passes medial to the center of the knee by a distance of average 8 millimeters. The joint conversions angle, which we talked about, we have 3 scenarios. On the non-weight bearing films, it could be 0, but it increases with stance phase that we call it varus thrusts. And it can be open during normal films. And in this case, we need to check whether this is a fixed deformity or correctable deformity by doing valgus stress. This is the scanograms. It takes the mechanical axis, measures the MEPTA, medial proximal tibial angle, and the distal lateral femoral angle, the joint conversion angle, the length if it has to be measured, and the CT, we do a cut by the head and neck of the femur and superimpose on the cut at the distal femur, and we check with the line passing by the back of the condyles to see the rotation or the anti-inversion angle. Another cut can be taken by the proximal tibia and the malleoli to check for the tibial torsion. Then we have to make a plan and measure the angle of correction. And to measure the angle of correction, we rely on the angle or rely on the distance. In the past, we used to judge by the angle. Like in this example, if the mechanical axis of the femur makes an angle with the distal femur, or its lateral distal femoral angle is 87, so it is, in this case, it is normal. There is no deformity in the femur. Looking at the tibia, it is 82, so it must be 87. So we have 5 degrees of varus at the proximal tibia, and this should be corrected with an overcorrection of average 6 degrees. Then we need to correct 11 degrees. The other way of planning is the mechanical axis. We take the mechanical axis of the femur, and if the joint line conversions angle is 0, then we make we take the angle between the mechanical axis of the femur and mechanical axis of the tibia, and this should be straight line. Here it is 8 degrees short of the straight line. Then the angle of correction should be these 8 degrees to make it straight and 6 degrees to make it over correction. So it is 14 degrees in this example. In the zero, when the mechanical axis is 0, then 60%, as we said, of the load comes on the medial condyle and 40% on the lateral. If we go up to 6 degrees of valgus, then reverse occurs. Medial load is 40% and 60% on the lateral femoral condyle, which should be targeted. We said that the mechanical axis pass medial to the center of the knee by about 8 millimeters, that we call it the medial mechanical axis deviation. And it is found that we should shift, if we do 6 degrees of overcorrection, we shift the mechanical axis to a point described by Fujisawa, that is middle in the, between the 1/3 and the lateral 2/3 of the lateral tibial condyle. Shifting the mechanical axis from this point on the medial side to this point on the lateral side makes an overcorrection of 6 degrees. So we can take the mechanical axis of the femur, not to the center, but to this Fujisawa point, and we make the mechanical center of the tibia from the center of the ankle to this Fujisawa point, and then we get this angle alpha. This angle alpha is the angle, if we correct, we get a straight line passing by the Fujisawa line, Fujisawa point. Whether doing an open wedge, medial open wedge osteotomy, or doing lateral closing wedge osteotomy. In this case, if we take this mechanical axis to the Fujisawa point and mechanical axis of the tibia to this point and extended, then we get this angle, which in this case is 14 points, 14 degrees. There is quite few computerized programs, computer program for making the digital planning. We cannot go through this now. And we go through the technique of the osteotomy. To start the technique from the beginning, Coventry in 1965, over 50 years ago, first described a closing wedge osteotomy, proximal rather than distal to the tibial tuberosity in these cancellous metaphyses. But realigning the tibia requires migration of the fibular strut posterior-superiorly, and this could only happen by freeing the proximal tibiofibular joint or doing a distal fibular osteotomy. Coventry concluded that the major complication was under correction and the recurrence of deformity with under correction. The risk of failure increased if alignment has not achieved 5 degrees over correction in the mechanical axis, and or if the patient was substantially overweight, that's 30% or more of the ideal body weight. The only limitation to larger amount of correction by closing wedge osteotomy is the size of the bony wedge that can be taken proximal to the patellar tendon. The Bauer et al. Described technique to assess this wedge, and they said that for each 1 degree at the base of the wedge, you get 1 degree of correction in the angle of correction. So if we need to correct the tibia by 20 degrees, then we expect the base of the wedge to be 20 millimeters. but this only works if the width of the tibia is 57 millimeter wide. Excision of much bone above the tuberosity led to a narrow segment of the proximal segment, where there is a little room for screw position, with a risk of malpositioning the screws in the osteotomy or in the joint, poor purchase of screws, or risk of osteonecrosis of the proximal fragments. And because of the funnel-shaped proximal tibia, lateral closing wedge osteotomy led to a step of deformity, which is of significance during later arthroplasty, where the offset of the joint is not in the center of the tibia. Osteotomy of the fibula distally rather risks the lateral collateral or lateral popliteal nerve, and doing the approach here with excision of such segment risk the vascular structures, and we put the plate below the anterior compartment risks the evidence or occurrence of compartmental syndrome. That's why came the idea of medial opening wedge osteotomy, by doing a cut from the medial side and open a wedge. This avoid the risk of doing the approach laterally and opening the anterior compartment. There is no touch to the fibula. You don't need to touch the fibula or superior tibiofibular joint, and you don't need to osteotomize the fibula and not risking the common peroneal nerve. There is no bone excision, and there is no step of deformity. This is the open wedge from the medial side, and this is the lateral closing wedge from the lateral side. So the medial opening wedge osteotomy is easy, single cut via small incision, and this produces a gap. This gap is maintained by a plate with a spacer, that's a metal block, or a locked plate with a fixed angle locked screws, or by a tricortical iliac bone graft and cast, structural graft material as hydroxyapatite wedges, which lacks structural strength, or by an allograft. Actually, the allograft was a common use in even in Eastern Europe. They just make a small cut, open the cut in the tibia, and put an allograft from the bone bank. The medial opening wedge osteotomy tends to increase the slope because we tend to open the gap more medially rather than posteriorly, more anteriorly rather than posteriorly. So it is an advantage in posterior cruciate ligament laxity. When you increase the slope, you prevent posterior subluxation. You increase the length of the leg, which may be an advantage if the leg is shorter. You tighten the medial collateral ligament, which again may be advantage because it decreases the external rotation laxity, which helps in posterolateral corner injuries. But the medial collateral ligament tension increase the tightness and load of the medial compartment and might need to be released. And it risks the interarticular fracture propagation if the tightness is too much. The cut, because it is above the patellar tendon insertion, it leads to extensor mechanism tightness with production of patella baja or low patella, which alters the mechanics of patellofemoral joint. It also has a disadvantage of poor skin coverage on the medial side, and the plates with the spacers comes with 2 millimeters increments that comes with an 8, 10, 12, 14 millimeters. So there is no, you are not free to do a fine adjustment. Probably the major drawback in these plates is the limit of correction, which is maximum of 14 millimeters, which is less than 14 degrees of correction. But the gap can be maintained by a locked plate, but it needs to structurally strong. The disadvantage of the gap is if it's a big gap, we don't fill it with a bone graft, you get a low union rate, which leads to slower weight bearing. Tomofix is a system which provide many advantages, special system for the upper tibial osteotomy. And we will present the technique with the preparation approach and points in the tips and tricks in the fracture propagation, stable angular fixation, and the golden screw. In the preparation, you should prepare and sterilize and wrap the whole lower limb. If you use sterile tourniquet, then you mark the hip joint, center of the hip joint, and put a mark on it, and you make sure that you can get a clear image of the hip, knee, and ankle, or the hip and knee, with good visualization of the knee in the AP and lateral views. The instruments you need is a set of flat osteotomes, which are graduated, a periosteal and laminar spreader, a bone spreader, a vernier calipers, and blunt Hohmann retractor. We do the approach on the medial side of the upper tibia, similar to the approach for harvesting the hamstring in the ACL reconstruction. So you are limited in the front by the patellar tendon, from the back by the MCL, distally by the pes internus insertion. And you clean the bone in this area. You might need to do a partial release of the medial collateral ligament and put a Hohmann retractor on the back of the tibia. Then you put 2 K wires just above the planned level of osteotomy and aiming to the top of the fibula. These 2 wires are the guide for the saw blade, and they support the medial part of the tibia, preventing inadvertent fracture propagation. And then with the saw, we cut the vertical limb parallel to the slope of the tibia, which may be marked by another anteroposterior wire, checked in the lateral X-ray. And with the saw, we reach to the distance 5 millimeters from the lateral cortex of the tibia.